Hey everyone, thanks for coming along today to our mental health update webinar, just a 1 hour webinar today as we move into Mental Health Week. My name is Anil Kamath. I'm the Director of Programs at Westvic PHN, and I'll be your facilitator this evening. So just firstly to acknowledge the traditional owners of the lands and waterways on which we all are today across this large region. I'm in Warrnambool, so that's Gunditjmara area. We recognise the First Nations people's diversity and resilience and their ongoing place in our communities. We pay our respects to elders past and present. Anyone else here today that is of First Nations background. We come together in a spirit of mutual understanding with respect and reconciliation. And at Westvic PHN, we support self-determination of First Nations people and also acknowledge the lived experience of those with mental health who've shaped a lot of the change that's happening across Victoria at the moment. So just some quick housekeeping for today's event. So this webinar is being recorded, and as you can see on there, we do have a YouTube channel where you can access this after the event or share it with your colleagues. And also just take a note, we have a lot of events that are coming up that you can register for. Just go to our website. We'll put in the link where these are coming up so you can register for those soon. And also just to take note of the health pathways that we have related to mental health. So if you don't have health pathways, there's some logins here and some ways to register to access health pathways. If you're not sure, please just reach out to Westvic PHN and we'll make sure that you can get access to those health pathways too. So yes, we're listening as a PHN. Every 3 years, we do a large needs assessment. And then throughout the year, we do this smaller needs assessment. And an important part of this is both, I guess, the quantitative data that we get, but also the qualitative data that we get from you and your patients. So there is a QR code here that you can scan, or if you go to our webpage, you'll be able to find a link on our project page about participating in our needs assessment and providing your views or your client views on issues that are relevant to them and to you. So please check that out as well. And just to note, so that everyone can get a certificate for today's event, if you notice that your name is not correct or if you're not sure, please just type in your first and last name into the chat box. The team will make sure that all your details are correct, and then you get that certificate of attendance as well. So at the end of today, there will be an evaluation on today's webinar. We've got it here now, just as a bit of a heads up, but at the end of the session, it'll also come up again. So feel free to scan it now or wait till the end of the session where you can scan, and we appreciate your feedback so we can keep improving how we deliver these events to you. Just to note today that it will be recorded and the Q&A session will be at the end of the event. If you have any questions, everyone is muted during the event, but if you have any questions, just type it in the Q&A component of the webinar, and at the end, I'll help facilitate a discussion based on those questions and bring in the relevant members that are talking today. So today we will have Taylor Davies from Mental Health Victoria, who'll talk about the Health Act. Katrina Wilson, Rachel Krepp, and Mara Taylor, all from the PHN, will also be talking about some mental health topics today. So I'll stop talking now and hand over to Taylor to talk about the Mental Health Act. Thanks, Taylor.
Good evening, and thank you, Anil. Firstly, I'd like to echo Anil's acknowledgement of the traditional owners of the land, as well as those with lived and living experience of mental health vulnerabilities that are making a profound contribution to our community and our workforce at the moment. So today's presentation, we will be going through the Mental Health and Wellbeing Act. So a lot of the significant changes, as well as some of the background as to why this Mental Health and Wellbeing Act has shifted. This Act is now enforced as of the 1st of September this year. So what we will be going through today is, like I said, the background around the legislative shift, where that's come from, and how that is applicable, particularly to the primary sector. Sorry, just a little bit of background about myself as well. So I'm Taylor from Mental Health Victoria. I am the project coordinator for the Mental Health and Wellbeing Act implementation within the community and non-acute sector. My background is in mental health nursing, predominantly in the inpatient setting, primary settings in a custodial environment, as well as acute emergency response. I've also been within education in the last few years for Victoria Police to improve their responses to people in acute mental health crisis, and have come over to Mental Health Victoria in the last few months. So the Mental Health and Wellbeing Act has changed recently in response to Recommendation 42 of the Royal Commission. So this response to change the Act has realistically come from a lot of people with lived and living experience, as well as their families and carers, expressing their concerns for the way that they were treated and the further trauma that is attributed to their experiences. So this Act is changing to support a mental health service that is responsive and is really particular to the needs and preferences of the person accessing the system. It is there to empower consumers and to respect their rights and maintain their dignity and safety as best possible. So for the primary sector, it means a few changes. So the whole sort of service delivery framework is shifting to be able for people to access supports within their community as first and foremost, rather than to follow in the hospitals. So this may mean a few more presentations within the primary sector, but also accessing and creating different services within the community and having that continuum of communication throughout those entities to be able to best support that person. So it's taking on a more holistic approach to mental health, moving away from what was predominantly more of a clinical or biomedical model, and moving into psychosocial supports. So as you can see, we've shifted from different elements or access points within the mental health and wellbeing service. First and foremost, people should be able to given the potential or capability to self-manage or use their own personal supports. However, if they do need further access, GPs will be the first and foremost contact point there. So this is not asking general practitioners to be experts in mental health, but it is just about supporting them to be able to know what other services or referral points may be best for that person, whether it be ongoing clinical support or whether it be more psychosocial issues that need to be addressed. So at the core of the Mental Health Act, there are 13 mental health and wellbeing principles. These are essentially the things that whenever we consider the Mental Health Act should come back to. These principles are very much about protecting the safety, autonomy and dignity of consumers, and they are realistically things that as people we would want to empower. So it is about empowering someone's choices. It is about empowering their own lived experience, leaning on their family and carers, and making sure that their cultural safety and gender safety, everything is looked at as a holistic standard. Now, there is an expectation that all mental health and wellbeing professionals, or those enacting powers under the Mental Health Act, do adhere to these mental health and wellbeing principles. So that's specified within Section 29 of the Mental Health and Wellbeing Act that states reasonable consideration needs to be given to those principles. These principles are realistically what the Royal Commission has all of their recommendations sort of encompassed into one to be able to achieve safety, emotional safety and physical safety, and has the ambition of reducing the use of compulsory treatment, which we know can perpetuate trauma of that individual. So these here are the 13 mental health and wellbeing principles. And with the 13 wellbeing principles, there are also principles regarding decision-making and principles regarding information sharing. As you can see, a lot of these mental health and wellbeing principles have carried over from the Mental Health Act 2014, particularly that of least restrictive interventions. What has been added in though, and one in particular, is that the dignity of risk of a person, in that the person should be able to make decisions where there may be some consequences, but if it's in the venture of personal growth and empowerment, then that needs to be given consideration. As well as looking particularly at the cultural safety of an individual, their gender safety, and the diversity of care is something particular to the primary sector. Looking that not one treatment will be specific for every person, that whatever the person feels as if is necessary to help them in their recovery should be given consideration, and that should be explored through their supported decision making. So on top of the mental health and wellbeing principles are the decision making principles. These decision making principles are there to guide or give support to the practitioner at the time. So it is about, again, respecting that the person should be treated in the least restrictive way, that there may be consequences for the practitioner of enacting compulsory assessment or treatment, and for that, whenever it is enacted, just to be able to justify why that decision was made at the time. Within this legislation, there is an immunity clause. So Section 141 of the Mental Health and Wellbeing Act states that if a decision is made in regards to that acknowledges the principles and then is made in good faith, but an incident does occur, this decision gives, I guess, some protection to the practitioners. Really acknowledging that there is quite limited benefit to restrictive interventions in the long term. So being able to balance that harm. And I know that I am guilty of this in the past as well, of sometimes maybe making decisions that are more protective of myself rather than in the best interest of the person. So this is where balancing those harms and traumas really needs to come into consideration, as well as giving that individual some choice. Then with the information sharing principles, it is always there are going to be cases where it is necessary to be able to disclose information of that individual. So that is particularly to when that information is pertinent to that person's ongoing care, or when there is an imminent concern for that person's safety. In those instances, information sharing would be quite reasonable. But for every other time, really acknowledging that where possible to get consent from that individual to be able to share that information within health services. And that can help them in the long term as well, because it can be very quite draining on the person to have to retell their story again and again. So if you do anticipate that that person may need ongoing supports, to ask consent to preemptively share some information so that other services such as area mental health services will know the background of that consumer. Making sure that we respect the dignity of the person as best possible and only disclose the necessary information at the time. And as best or as reasonably practicable to make sure that information shared is accurate without speculation. Now, when it comes to some of the shifts of the Mental Health Act within the primary sector, something that is pre-existing within the 2014 Mental Health Act but may be seen more often going forward is in circumstances where police or PSOs take someone into what we're now calling the care and control. So Section 232, Care and Control, is replacing what was previously Section 351 of the Mental Health Act, Apprehension. Under the previous Mental Health Act of 351, police officers were able to take that person to a registered medical professional. However, it was not always something that was regularly done. One change now is that when someone is taken into care and control, it is necessary for that police officer to arrange as best possible to get that person assessed within the community or near the place that the event had come into effect. Now, this is something that may not always be logistically possible because of GP opening hours or because of potential safety concerns of that consumer. And police officers will do that risk assessment preemptively. But there may be situations where persons under Section 232 are presented to GP clinics. Where best possible, police will try to preemptively arrange this to give advice that that person is coming in. But legislatively, they are correct in being able to bring them to a registered medical practitioner, particularly in rural areas where hospitals are quite vast distances away. One thing that I've seen in some communities happen is that within certain rural communities in particular, memorandums of understanding have been developed. So this may mean that local police, ambulance, hospital service, and certain GP clinics have arranged under what circumstances may a person be brought into their care, and what parameters surround that examination. With this happening, as I said, this will only be an option if, one, it is logistically possible, and two, is safety is not an acute concern at the time. What may sort of divert this from happening, and where again some potential memorandums of understanding can occur, is that currently under Section 228, this is going to stump me, under Section 228, police officers, before enacting Section 232, it does as best possible need to be a health-informed response. So this may mean that police could call the local GPs to ask for advice about the regular person's care, or they may have the person first seen by a paramedic to make some determination, or talk to a registered nurse from a hospital or mental health triage lines. So it may not necessarily change the presentations that do come through. If someone is received by a GP under this section, it is up to the GP to make that determination as to whether that person does or does not need to be on an assessment order. So as of the previous Act as well, there is the options for both a community assessment order and an inpatient assessment order. So if a community assessment order is made, it would be up to that practitioner to make contact with the local area mental health service, fax on that form, and that the area mental health service does have, I believe, 72 hours to come and assess that person in their own communities. Now, an inpatient assessment order can only be made if the practitioner deems that it is not safe at all for that person to remain in that community. So this is where having those open conversations or be able to liaise with area services could be something that gives, I guess, consolidation or helps with accountability in making those decisions. And as per your usual escalation pathways, if the person is not appropriate or too acute at that point, you can always still make that referral where the criteria fits. So looking at assessment orders, both as inpatient and community assessment orders, the criteria has remained the same from the previous legislation. So that person appears to have a mental illness, and because of that mental illness, the person needs immediate treatment to prevent either deterioration of their mental or physical health, or to prevent serious harm to themselves or to another person. This can only be done if there is no lesser restrictive means that is practicable for that person. So this determination very much does need to take in consideration the least restrictive principle, the dignity of risk, particularly for people that may be expressing suicidal ideation, but perhaps not imminency or intention at the time, as well as the needs and preferences of the consumers. So that might be particularly relevant to when deciding between a community assessment order and an inpatient assessment order, and that balancing of harm in regards to decision making. When communicating under the Mental Health Act, whenever expressing, particularly if an assessment order is being made, the practitioner must take reasonable steps to make sure the person has the appropriate supports to understand that information. So whether it be addressing any accessibility needs, but they do have to make extended efforts to really ensure that the person has understood what is being said in that moment. In regards to making that assessment order, there's also additional criteria in that GPs must identify who they are, identify what they intend to do, and explain the purpose of the examination. So there are certain rights, well, there never always have been, but there are an extension of rights now for consumers as well as their friends and families that medical practitioners do need to be aware of. So again, particularly at certain access points along the person's mental health journey. There are things called now a statement of rights that set out what the person's rights are and the process that's applying to them. So this is at certain points within the person's journey of receiving care. And at these defined points, including when making an assessment order, GPs are responsible again for making that extended effort to ensure that the person understands their rights. There is a statement of rights form that should be given to the person, and it does have to be the actual form itself rather than just a verbal explanation. We have that form available in the resources that we'll give at the end of the slides. It may also be necessary to ensure that the person's friends and families are aware of the person's rights, particularly if they have a predefined nominated person of support, which we'll go through shortly. One of the key principles in this legislation is the supported decision-making of the individual, so that all persons receiving mental health and wellbeing services should be given information about all services that may be available to them, be given thorough explanations, and be heavily involved in regards to their decision-making and assessment to achieve best treatment and recovery going forward. So with this, it does again address that dignity of risk principle. So from a clinical outset, there may be something that often that we're going to disagree with, but unless there is foreseeable, imminent and serious risk to that individual, they do have the right to make bad decisions in order to achieve personal growth. In line with the diversity of care principle, again, people may need different things along the journey. So those psychosocial supports, they may benefit at the time from care from someone within the living experience workforce. They may need dietetic support. They may need medications or hospital stays, but they should have the choice to be able to be aware of the choices and execute that. Where possible, if they want to have supports with them, absolutely, to be able to support them, advocate them, and be able to help them and feel empowered to make their own decision in a time of vulnerability. And it is really important from a clinical aspect that we deliver care that's collaborative rather than dictating what we think the person needs at the time. And mental health should be treated like every other health condition. There are going to be periods of wellness. But for most physical conditions, we would take the prevention and promotion approach first and foremost. So really giving psychoeducation, trying to deliver services that will be able to help them in their state of wellness to be able to prevent incidents of unwellness. And it does need to be aligned with what the person chooses as per the preferred recovery journey. Medical and other health needs often interact with each other as well. They can be very co-occurring. So they're going forward under the health needs principle, trying not to segregate mental health issues away from physical health issues, that they should be treated concurrently. And this includes the health needs pertaining to the use of alcohol and other drugs. Again, this is where the dignity of risk principle may apply, in that if a person is having recurrent mental health episodes because of alcohol and drug use, again, that is a decision that the person is choosing to make. So it can be very difficult balancing those harms. And of course, if the person does become a serious risk, both medically or due to their mental health, there is always that escalation pathway that can be followed. There is also within these principles as well the well-being of dependence principle. So given that we're looking after the holistic approach, there can be family stresses going on, or there can be impacts within the family. So there are provisions for mental health practitioners and medical practitioners to be able to protect the rights of young people or other dependents of those that are receiving mental health care. So one thing that is going to be promoted quite heavily within this Mental Health Act is advanced statements of preference. So this has changed its semantics from advanced statements. With advanced statements of preference, this is what people are able to preemptively dictate what their treatment will look like going forward within reason. It doesn't pertain only to clinical treatment, but it also pertains to other aspects of the person's care. So whether it be sensory environments, whether it potentially be community assessment orders versus inpatient assessment orders. And the criteria has shifted away from, in regards to witnessing. Previously, only authorised persons were able to witness these advanced statements of preference to make them official. And that meant generally that people would have to first come into that hospital environment, into that inpatient environment, before being able to make an advanced statement of preference. So it was slightly counterintuitive. Now these can be made at any point of time. And looking at preventative care or keeping care in the community, it will be quite largely resting on community organisations or within primary care to have those proactive conversations with the person about what they would like their care to look like going forward. Within the hospital setting, if a person does become unwell, there are sections in which this advanced statement can be overridden, particularly if the person is at imminent risk of harm. But that does have to be heavily justified by that practitioner in that setting. And reasonable efforts should be made by not only mental health and wellbeing service providers in the community, but anyone that's giving care for that person for mental health concerns in creating these plans or making inquiries that whether this person has a plan in place. This also goes for nominated support persons. These nominated support persons are essentially there to advocate for the views of the person and help them communicate their needs and their decisions in that moment. Again, the criteria has shifted slightly that this person, if there is a nominated support person, it does not have to be witnessed by an authorised person. But the nominated support person does need to agree that they are that person and happy to be that advocate. And there are certain points along the mental health and wellbeing journey in which NSPs must be notified. This includes when assessment orders are made. That's why reasonable efforts should always go in place to ensure or explore that that person does have a nominated person of support. I'm sorry, that was a lot of information in a short period. But there are additional resources that may be able to support the ongoing implementation of the Mental Health and Wellbeing Act. So, as the project coordinator for the community and non-acute sector, I am more than happy to answer and field any questions that may come through about this legislation. I will put my email shortly within the chat. But the Department of Health have formulated a lot of dedicated resources towards the Mental Health and Wellbeing Act implementation. They have a specific landing page for the Act, which includes fact sheets that have comparisons of the two acts. There is a specific fact sheet that is relevant to GPs and some of the changes. For all of those things that I spoke about, the assessment orders, nominated support persons, and the advanced statements of preference, those forms can all be found on the Mental Health and Wellbeing Handbook page. And there is also a dedicated e-learn product that has come out from the Department of Health. So this is 5 modules that are available on MHPod. Anyone can register for MHPod, so it is quite easily accessible. And it does break down the legislation a fair bit. There are also specific case studies, including one in the primary sector. Now, with my role, the Department of Health has funded Mental Health Victoria to support the implementation for a whole 12 months post commencement of the Act. So that means that whatever the community and primary sector need, we are more than happy to try and get those supports out to you. So this might include tangible resources. This may be face-to-face forums in your area or online question and answers once there's been time to contextualise. But realistically, if you have any suggestions about what you would like to see to support the implementation of the Act, then please, like I said, email me. I'm more than happy to work with whatever the community needs at the moment. Now, just trying to see if there's some questions. One thing that is shifting in particular in regards to the service delivery framework, and which you may start to see a lot more of, is the mental health and wellbeing locals. So at the moment, there are only 6 mental health and wellbeing locals that are active within Victoria, but we're hoping to get to 50 in the next couple of years. So this would essentially be the step up from the primary sector, and it is predominantly a psychosocial based service. It is a completely voluntary service with no coercive treatment or interventions, but it does give a lot more accessibility and comfort to the consumers. So within the rest of the Western region, there are a few coming up. There is the Mental Health and Wellbeing Local at the moment in North Geelong, and that's run as a consortium between Barwon Health, Irma and Wellways. They have had a really good response so far. However, there have been some limitations in advertisement, as well as just that cultural shift into what mental health looks like. And that's something that really does need to be addressed largely, is the destigmatization of mental health as being something separate or something that's not ever going to be relevant to ourselves, and being able to treat it in unison with all other health concerns. Now, that's it from me at the moment. Is there any questions that I could, any questions, I'm sorry, will be fielded at the end, I believe. But please, I'm more than happy to put my email in the chat.
Right, thanks, Taylor. I just put in to the chat. If anyone has questions, just start populating that now in the Q&A area while we've got Taylor, and can pepper her with some questions. But thanks very much for that, Taylor. Great to see that you're here supporting the community for that period of time, and I'm sure a lot of people will be reaching out to you.
Yeah, please do.
Thanks for that. Next, we'll hand over to Rachel and Katrina, who will be talking about Thru Care.
Hello, everyone. Thank you firstly for taking the time to attend this presentation. My name's Katrina, and I'm a Program Development Consultant at Western Victoria Primary Health Network, as is my colleague Rachel, who is also co-presenting. Today, we're presenting to you on Thru Care, our integrated mental health and AOD model, which commenced on the 1st of July this year. The purpose of tonight's presentation is to enhance your knowledge on the Thru Care program and highlight the eligibility criteria and referral pathways. This will include both consumer self-referral and the GP referral pathways. But first, we'll play a short video about Thru Care and how we got here.
A new service model in Western Victoria. Thru Care, Regional Care Partnerships, Mental Health and AOD.
The Royal Commission into Victoria's mental health system found that many people experience co-occurring AOD and mental health support needs. Blended treatment, care, and support is not readily available to everyone, and there is a lack of integration across the health system.
To develop our model, we worked with teams across our PHN to gain an understanding of our health system.
We used co-design to listen to the experiences of our community and our service providers.
We worked with groups who could give us valuable insights into the needs of our region.
The initial steps were formed around co-designing a bespoke solution. An evaluation of available resources was conducted before model design and building specification.
Market sounding was conducted to explore key themes with interested parties. It also gave an opportunity for the market to ask questions, seek clarification, and discuss issues. Industry briefings were an opportunity to provide information to tenderers in a fair and equitable manner. They provided a space to ask questions and request detail beyond what is captured in the tender documents. We learned that the providers of mental health and AOD services in our region were ready to work together in a more integrated way.
It was important that our model aligned with not only Westvic PHN strategy, but with national and state strategic directions.
Until now, funding for mental health and AOD has always been separated. We worked with our executive team and board to bring mental health and AOD funding together. A key element to our model is to structure funding in a way that encourages partnerships.
We had 10 main objectives that we wanted the partnerships to help us achieve. Most importantly, partnerships simplify the journey for a person requiring mental health and/or AOD care.
Our partnerships demonstrate innovative models of care and work towards addressing workforce challenges and how they can be overcome. Our funding is designed to service sub-regions, which acts as a lever for organizations to create partnerships. Sub-regions also ensure that all local communities have access to services.
A blended funding model gave us increased flexibility, improved access to services, increased efficiency by reducing the number of contracts, and improved the sustainability of programs.
People engaging in treatment are at the center of their care. The model is designed to ensure coordination of care that includes all practitioners and GPs. Shared communication is embedded in contracts and is an enabler of collaborative care.
Considerations needed in the development of systems to support the model are the data requirements, the functionality of reporting, and how the data will drive performance management of contracts.
Thru Care, Regional Care Partnerships, Mental Health and AOD. Growing the way we deliver care across Western Victoria. A new service model in Western Victoria.
So what are the new services that we're delivering under Thru Care? Thru Care is aligned with the stepped care approach from level 1 to level 4, with level 1 being the lowest intensity care and level 4 being the highest intensity care. Level 5 acute services are out of scope of the model. So the model aligns the level of need with the services delivered to address co-occurrence of mental health and substance use problems in many people's lives. The stepped care approach also enables mental health and AOD clinicians to work at their full scope of practice, supported by non-clinical workers with the lower intensity consumers under appropriate supervision. For AOD programs, We're providing appropriate care and support across the continuum of AOD use, including brief interventions, screening and assessment, counselling, dual diagnosis, group interventions, and home-based withdrawal. We have low-intensity mental health services, which are for people at risk of mental health issues or with mild mental health issues and do not require more intensive psychological interventions. People who access this service with complexity indicated by significant problems in risk, functioning, or coexisting conditions are considered contraindications for level 1 and 2 of care, and this would trigger a referral to level 3 or higher with a warm transfer approach. We then have structured psychological therapy, which can be accessed by all priority groups as long as it's not duplicative of other services. And high-intensity mental health treatment and care coordination for people with severe and or complex mental health issues. We can access these services as long as they're not duplicative of other services and the consumer doesn't require acute services. So services for suicide prevention can also be delivered across all levels of the model.
The Commonwealth funding that supports the delivery of the Step-Through Care model is designed for consumers from priority group settings. This is a free service to support those most at risk. Step-Through Care services are eligible for consumers who meet low income thresholds, who hold a healthcare card or other concession card, live in rural and remote communities who do not have access to the appropriate services, are experiencing short-term displacement or homelessness, who identify as LGBTQIA+, are Aboriginal and or Torres Strait Islander peoples, living in areas impacted by natural disaster such as drought, from culturally and linguistically diverse backgrounds, people experiencing perinatal depression, consumers with an intellectual disability and who are experiencing AOD and or mental health issues who are encountering barriers when accessing care, experiencing or at risk of domestic violence, and young people who do not have access to other services such as Headspace, and children under the age of 12 years.
So now that we know the priority populations, let's have a look at how consumers can access Step-Through Care. As you can see from this slide, on the left-hand side of the screen, there are multiple pathways into the Step-Through Care program. Early in our model design, we knew that we wanted to break down the barriers to accessing support and to simplify the referral process. Consumers, their natural supporters and their carers can call the central intake team directly via the 1-800 number, and the central intake team can then provide information on available services, or if the consumer is ready and consents, an IAR can be completed and the central intake team will allocate the consumer to the most appropriate service in their sub-region. This includes Step-Through Care, Head to Health and Headspace. Following the assessment and referral, the central intake team will also follow up with the consumer again within 7 days to see how they're progressing. Alternatively, GPs can send their referral to the lead Step-Through Care provider in their sub-region. GP referrals through to Step-Through Care need to be sent via secure messaging and do not require either a mental health treatment plan or a K10. However, these can be provided if they've been completed. It's also really important that it is clearly noted on the referral if the client is at risk of suicide. Once a client's information is received by the Step-Through Care provider, unless already completed by central intake, an IAR, and where appropriate, AOD assessment tools are completed and consumers are assessed for both mental health and AOD needs and matched to the appropriate level of care for either blended mental health and AOD or independent mental health and AOD needs. Consumers can receive mental health and AOD care at different levels at the same time. For example, an AOD brief intervention at level 1 and structured psychological therapy at level 3. If consumers are identified as having acute needs, they will receive a warm transfer to an acute service. GPs and other referrers can provide advice and recommendations for the type and level of care consumers might need in their referral letters. Otherwise, referrers can simply refer to the service and the provider will create a care plan with the consumer and update the referrer on their recommendation and for the ongoing care of their consumers.
This is what we envisage a consumer journey may look like via Step-Through Care. This may vary between sub-regions and individual presentations and circumstances. Priya has presented to her GP seeking help. Priya is a 26-year-old and advises her GP that she has been consuming alcohol since age 15. Her alcohol consumption started shortly after she was assaulted by a family member. Priya's GP refers her to Step Thru Care. An AOD clinician completes the initial assessment and referral, known as the IAR, and Priya is suspected of having co-occurring mental health and AOD needs. In a spirit of collaboration, the AOD clinician contacts the mental health clinician within the Step Thru Care partnership, and Priya receives the appropriate treatment for mental health and AOD in collaboration to reduce the need of Priya retelling her story. Priya is finding it difficult to talk about the sexual abuse experience due to feelings of shame and stigma. A qualified peer worker with lived experience is also engaged in Priya's care to connect and to provide emotional and social support through Priya's journey. A multidisciplinary team, including Priya's GP, mental health clinician, AOD clinician, and peer support worker, will continue to monitor Priya's mental, physical, and social health needs as an interdisciplinary care team in an effort to enhance her overall well-being.
In the journey to Step Thru Care and in the first 3 months of operation, we've identified some common themes and some questions about the program, accessing care, and what other options may be available to support your consumers. So what happens if your consumer needs an interpreter? Step Thru Care providers have access to an interpreter service. If your consumer requires an interpreter, please make this clear in your referral. What happens once I refer? The Step Thru Care provider should be keeping you updated at key points within the consumer's care. You can contact the Step Thru Care provider directly if you have a question or if you require further information. What happens if a consumer is on an NDIS package? NDIS participants are out of scope for Step Thru Care and will be warmly transferred to an NDIS provider. Where a consumer is referred with an intellectual disability who are experiencing AOD and or mental health issues and barriers to accessing services, Step Thru Care may be able to provide some supports, including service navigation, to complete an NDIS application. What if the consumer is aged 12 to 25? In general, consumers aged 12 to 25 need to be warmly transferred to Headspace, and GPs are encouraged to refer directly to their local Headspace. However, in some circumstances, Step Thru Care might be the right option to support young people where they don't live near or have access to Headspace. They fit within multiple priority groups within Step Thru Care, and Step Thru Care can better suit their needs. Or they're mature, aged 18 to 25, and would prefer to be seen outside of the youth-oriented Headspace model. If a Step Thru Care provider receives a referral for a consumer who is more suitable for another service, the Step Thru Care provider will ask for consumer consent to warmly transfer the consumer to a more suitable service and notify the referrer.
Step Thru Care is delivered through a partnership-led approach. As you can see from this slide, there are 4 partnerships delivering Step Thru Care across the Western Victoria PHN region. These include Ballarat Goldfields region, which is serviced by lead agency Ballarat Community Health in partnership with Maryborough District Health Services and Central Highlands Rural Health. In the Geelong Otway region, services are provided by lead agency Nemo National in partnership with Windana Drug and Alcohol Recovery, Drummond Street Services and the Watherong Aboriginal Cooperative. In the Great South Coast region, services are provided by lead agency Mind Australia in partnership with Rad Health, GenU, Brophy Family and Youth Services and Portland District Health. And in the Wimmera Grampians region, services are provided by the lead agency Uniting in partnership with Grampians Community Health.
Thank you all very much. That brings us to the end of our presentation. After this session, you'll receive a post-presentation pack from our team. It will include information about how to refer within your sub-region and information around levels of care. For more information about how to refer for lead agency contacts or information about Step Through Care in general, you can click on this QR code and that will take you to our website. But I'll hand back, we're done now, so I'll hand back over to Anil.
Great. Thanks, Kat and Rachel. Very informative. Next, we'll hand over to Mara, who's going to talk about the intake and assessment tool and the training that's available for clinicians in the region. Thanks, Mara.
Thanks, Anil. Hi, I'm Mara, and I'm here to talk about the IAR and the training. So I'll just share my screen. Okay. The IAR is an initiative of the Australian Department of Health and Aged Care and brings together information from a range of sources, including Australian and international evidence and advice from an array of leading experts. The IAR is an online digital support tool to assist general practitioners and clinicians to recommend the most appropriate level of care for a person seeking mental health support. It provides a common approach and language for communicating the intensity of the treatment response or level of care across service providers. It maps assessments across 8 interactive domains to determine the level of care. The IAR is used as an appendage to a mental health assessment, and it applies a stepped care approach. The initial assessment and referral decision support tool provides a consistent framework to deliberate decisions when making a person's mental health needs with the right level of service intensity at the right time. The IAR DSP assessment is undertaken using 8 initial assessment domains that are used to match clients to one of the 5 appropriate levels of care. The 8 domains help to distill essential assessment information and identify key signals that are crucial for decision making. The stepped care approach and the 5 levels of care are shown on this slide. Westvic PHN has mapped out local mental health services by IAR levels of care within our regions. The Westvic PHN mental health team has also developed service directories to assist in finding the right service or package of services for people seeking mental health support in our regions. So what are the benefits of the IAR? The tool improves understanding about how decisions relating to referral suitability is made. The consumers are referred to the appropriate mental health service. The tool minimises risks that arise through underservicing and overservicing, and the widespread use creates consistent language around the mental health across the mental health sector. Westvic PHN provides online training and support to assist GPs and clinicians in using the IAR DST. The training is designed to provide you with all the information you need to use the tool in your everyday practice. The training is a 2-hour interactive workshop and is RACGP and ACRIM accredited. GPs can choose to participate in online training or face-to-face training, and a reimbursement of $300 for GPs is also available. After the IAR training, you'll be able to describe the initial assessment and referral development process, describe the 8 assessment domains of the initial assessment and referral, distinguish between the levels of care and determine regional services appropriate to patients' needs. You'll be able to apply the decision support tool to generate a recommended level of care appropriate to the patient's needs, and you'll be able to apply the principles related to clinical decision-making and consumer choice into practice. At the end of this webinar tonight, you will all be receiving the training flyers with how to register for the training and also my details if you'd like to contact me directly. Thanks, everyone, and I'm looking forward to meeting you all again soon.
Great, thanks, Mara. I've actually done the training. It's very informative training and understanding how this national IR tool is being rolled out. And it also helps understand for services such as Thru Care, the process that they go through when working with clients. So we have a few minutes left for questions. If you just look at the bottom of your screen, there's a little Q&A button. Feel free to click on that and pop in any questions. But I'll start with the first question that came through, and it's actually for the Thru Care model, and it is, what is a warm transfer approach? So I might take that on and then hand over to Kat or Rachel if there's other things to add. But essentially the warm transfer is, the idea is that if a consumer needs other supports or additional supports, that the treating clinician or the treating service will actually work with the client to call the other service, provide the relevant information and help them book in that service and coordinate them to that new service. So in a sense, it's like the opposite of giving them a referral and telling them to go to that service themselves. So it's actually like guiding them and making sure they get the service. So it's really about making sure that people don't fall through the cracks when they have to go to other services. But I'll just pause for a moment, and Kat or Rachel, is there anything else that you think needed to be added to that?
I don't think so, Anil. I think when you cover it, it's about consumers not falling through the cracks and just providing that handover and not just one closed door and another one hoping that the next one will open. It's providing that complete handover and follow up. I think you've nailed it.
Thanks, Kat. Question for Taylor. So at the moment, what are the main kind of questions or concerns that are coming through from the primary care space around the changes in the Act, or the areas that they're seeking most advice and support on?
Predominantly through logistics, I would say, in that with potential capacity for emergency services to present to GPs, GPs aren't able to all of a sudden be able to get the workforce to help support that. And there's no expectation of that whatsoever. So if it is not logistically possible for a person to be presented to a clinic, then that was an option that was explored, but was not the most appropriate at the time. So there have been a lot of requests about potential funding into primary services. That one's a little bit out of my scope in regards to legislation. That's definitely more of a service delivery area. I'm sorry. Dealing with certain acuities, as well as having a lot of concerns that GPs have to know everything. Realistically, they deal with all sorts of vast presentations, and having concerns that they may not be mental health experts per se. The legislation isn't asking GPs to be experts. It's realistically about listening to the person, assessing risk for real serious and imminency, and seeking advice from other agencies if they're not sure to help support that decision. So contacting the area mental health services would be the best, because it is a direct referral, which they do have to act on in those instances. So whether it be with follow-up calls, whether it be with face-to-face presentations, that's a decision that they'll make on their end through their own triaging tools. But if there's ever any uncertainty in those spaces, to reach out to mental health specialists. Oh, you're on mute, Anil.
Thanks, Taylor. Thanks for letting me know I was on mute. And I think, Taylor, you said we'll send around your details after today, around if people are looking for additional information during your 12-month period as well. And a question for Mara. Do you have any feedback on the experience of people going through the training and how they've found learning about those levels, and their thoughts on how it's helped them in their practice?
Yes, we've had some feedback from a lot of clinicians who find it very useful in their role of referring people into the right services. GPs also are using the tool, and once to start with, you have to learn how to use the tool, of course, and then they find it quite easy to be able to refer people over in a small amount of time.
Great. Thanks, Mara. Well, thanks to everyone for participating today. Thanks for all the speakers for taking the time to present and answering the questions. So I really appreciate if people wouldn't mind completing the survey, QR code there, or cut and paste, or maybe you can't cut and paste the link, I'm not sure in Zoom. Maybe QR code's the easiest way. I really appreciate if you could go in there or click on the link in the chat and update that survey. And feel free to reach out, provide any other information or any other trainings that you'd like in this space too. Thanks, everyone. See you next time.